Good morning, good afternoon, and good evening, everyone, from wherever you are around the world. We welcome everyone to this new episode, the 15th Migraine Masterclass, Migraine during Menopause, Treatment and Oral CGRP Antagonists. We were lucky to have the Migraine Masterclass running now for this 15th edition, and we have a wonderful audience and speakers. These events are organized with the IVPN NeuroPsychiatry in collaboration with the Association of Migraines Disorders and kindly sponsored by Visor. Our moderator tonight is Dr. Mustafa Shaqra. Dr. Shaqra is a consultant neurologist at Sheikh Khalifa Medical City, Abu Dhabi, UAE. He has particular interest in inflammatory and degenerative diseases of the central nervous system. He runs the clinics of multiple sclerosis at SKMC. Dr. Shaqra has graduated from medical school at Damascus University in 1992 and received his main training in general internal medicine and neurology subspecialty in the major university hospitals. He carries MD and Masters and MRCP and FRCP in medicine and neurology, and additionally, he has authored and co-authored many articles in the field of neurology. We welcome you, Dr. Shaqra, with us, and we would encourage everyone to use the Q&A to interact with the speaker during the sessions and address your questions. We will be taking questions after each of the speakers is finished. Dr. Shaqra, are you with us? Let me double check with Dr. Shaqra. Okay, until Dr. Shaqra can join us, we will be starting with our first speaker, who is Dr. Caroline Stowe. Dr. Caroline is trained at the College of Charleston, the Johns Hopkins University, and George Mason University. She has been practicing as a family nurse practitioner for the last 14 years and has a specific interest in telemedicine, primary headache disorders, and sexual reproductive health, including menopause. Caroline is on faculty at George Mason University School of Nursing in the MSN FNP program and lives in Fairfax, the US, with her husband and 2 children. Please, Dr. Caroline, the floor is yours. You can start your presentation.
Thank you so much, everybody. I'm going to share my screen, and please let me know if you can or cannot see what I am seeing. How does this look?
Perfect.
Okay, thank you. Good evening or good morning, depending on where you're joining us from today. My name is Caroline Stowe, and I'm a doctorally prepared family nurse practitioner in the Washington, D.C. area of the United States. As both a headache and menopause specialist, I carry an additional qualification in headache medicine from the National Headache Foundation, as well as being a Menopause Society certified provider from the Menopause Society of North America. I have the pleasure today of speaking on the management of migraine symptoms during perimenopause, menopause, and some effective treatment strategies that exist today. I have no financial relationships or disclosures to report, and I also want to ensure that you know the information presented today is considered up to date as of today, but information changes so quickly in the headache world and the menopause world that very soon it may be considered out of date. So first, I like to define what we're talking about from the start. Migraine isn't just a terrible headache. It's a disabling neurological disease with different symptoms and different treatment approaches compared to other headache disorders. All of us who work in neurology and headache medicine know that the migraine brain is a hyper-excitable brain. I also want to state that my use of the word female, woman, women, she, her, hers pertains to all individuals who may not identify as such, but biologically can experience perimenopause and menopause. Now, perimenopause is the time in a woman's life when menstrual periods become irregular as she approaches menopause. This is usually about 3 to 5 years before menopause and is often marked by many of the symptoms of menopause, including hot flashes, mood swings, night sweats, vaginal dryness, trouble concentrating, and infertility. And then last, looking at menopause, it's the final menstrual period and is usually confirmed when a woman has missed her period for 12 consecutive months with no other obvious causes. So why do we care about migraine? Well, it affects over 1 billion people worldwide. It has a very high prevalence and morbidity, especially among young adults and women. In 2016, globally, it was the second largest contributor to the disability-adjusted life years lost due to neurological disorders. It is the highest cause of disability among women ages 15 to 49. This is a huge time for women, right? 15 to 49 is they are their most productive years. They're starting and finishing their education journey. They're potentially getting married and having children. They're starting careers. Their careers are flourishing, and they're caring for family, whether young or older. All of this is happening during this time period. We know that it disproportionately affects women, with the overall prevalence being about 20.7% in females and 9.7% in males. And this number right here, 42% of all women will have had an episode of migraine in their lifetime. That's almost half of all women. That's huge. Now, the woman's reproductive cycle is regulated by the hypothalamic hypophyseal ovarian axis through the release of estrogen and progesterone. Variations in the levels of these hormones and of their feedback control regulate the menstrual cycle, pregnancy, and menopause, among other things. Estrogen is the key hormone responsible for this fluctuation. Estrogen has facilitatory and inhibitory effects on various neurotransmitter systems, including the serotonergic, glutaminergic, opioidergic, and GABAergic systems. Estrogen receptors occur in the trigeminal ganglion, and animal studies have shown that estrogen modulates calcitonin gene-related peptide, CGRP, expression in the different components of the trigeminovascular system. The role of progesterone is a little less clear. It mainly activates GABAergic systems and can modulate the actions of estrogen in the central nervous system. Now, we know the sexes are equally affected before puberty, highlighting the importance of hormonal influences. But once girls reach puberty, we generally see more migraines. Throughout the reproductive years, menstruation is one of the most significant events related to the occurrence of migraine attacks. Compared with all other phases of the menstrual cycle, the incidence of migraine without aura is greatest during a 5-day window that starts 2 days before the onset of menstruation and continues through the first 3 days. Now, most epidemiological studies have demonstrated that the majority of women suffering from migraine note remarkable and increasing improvement of their attacks during pregnancy, from the first to the third trimester. Improvement is more likely in women with a history of menstrual migraine. If migraine does not improve by the end of the first trimester, it's likely to continue throughout their pregnancy. In fact, a small number of pregnant women will experience a worsening of their migraine, while a few others may even develop de novo migraine symptoms. The worsening usually occurs during the first trimester and involves women suffering from migraine with aura rather than migraines without. Recent data show that approximately 1/3 of all perimenopausal cycles have a major surge in estradiol occurring de novo during the luteal phase. This phenomenon, called luteal out of phase or loop event, may explain a large proportion of symptoms and signs for symptomatic perimenopausal women. A wave of follicle growth that is initiated in the prior luteal phase causes very early ovulation, immediately after or concurrent with menses from the prior cycle. Higher estradiol levels and rapid re-exposure to progesterone result. Now, during the transition to menopause, some women may experience a worsening of the migraine attacks, but usually postmenopause is also associated with relief. The type of menopause has a substantial effect on migraine. Natural menopause is associated with a lower prevalence of migraine compared to surgical menopause. The longer the time interval is from menopause onset, the greatest is the association with improvement. Whether migraine is associated with other menopause symptoms is still unclear since there's conflicting data and more studies are being done. In contrast to the effects of menopause on migraine without aura, prevalence of migraine with aura does not generally improve with menopause. Now, estrogens are a group of hormones that play an important role in the normal sexual and reproductive development in women. I love this picture because it pretty much affects everything, right? These are also known as sex hormones, and the woman's ovaries make most estrogen, although the adrenal glands and fat cells also make small amounts. In addition to regulating the menstrual cycle, estrogen affects the reproductive tract, the urinary tract, the heart and blood vessels, bones, breast, skin, hair, mucous membranes, pelvic muscles, and the brain. Secondary sexual characteristics such as pubic and armpit hair also start to grow when estrogen levels rise. And many organ systems, including the musculoskeletal and cardiovascular systems and the brain, are also affected. Now, I also want to call out that estrogen helps preserve bone density, and we know that osteoporosis is such an important issue in our postmenopausal women. Now, to learn more about women's health and specifically hormone replacement therapy, the National Heart, Lung, and Blood Institute, the National Institutes of Health, also known as the NIH here in the US, started a large study in 1991. It was called the Women's Health Initiative. And the hormone trial had two studies. We had the estrogen plus progestin study of women with a uterus and the estrogen alone study of women without a uterus. Both studies were concluded early when the research showed that hormone replacement did not help prevent heart disease, and there were some increased risk for some other medical problems. So the FDA here in the US states that hormone therapy should not be taken to prevent heart disease. Now, I like this graph because it shows just how impactful hormones are on individual triggers occurring at least occasionally. Hormones is number 2, stress is number 1. Somehow I doubt that surprises anyone here. I also think it's important to point out that so much of what triggers migraine can feel uncontrollable, but there are several things we can help encourage our patients to do to help regulate that hyperexcitable brain. We know a migraine brain likes things to stay the same. So for example, you can see here sleeping late can be an individual trigger. So if they're only getting migraines on the weekends, talk to them about the fact that maybe it's sleeping later that does it to them, and have them set their alarm to get up at the same time every day. That might just fix it. Now, menstrually related migraines defined as attacks that occur in the perimenstrual period, but can occur at other times of the cycle as well, while pure menstrual migraine is diagnosed when attacks are purely confined to the perimenstrual period. This is important to understand as the treatment options can vary between the two. If someone has pure menstrual migraines, the shorter acting triptans like sumatriptan don't generally work. The longer acting ones like Frova and naratriptan will be better suited to provide relief. And for example, we use Frovatriptan. It's a 2.5 milligram tablet by mouth, either daily or twice daily for 6 days, starting 2 days prior to onset of their anticipated menstrual migraine. And naratriptan is the 1 milligram by mouth twice daily for 5 days, again, starting the 2 days prior. Now, the trick here is that these menstrual periods need to be predictable, right? And we know that's not always the case with our patients, and a typical menstrual cycle can shift. And many women don't have regular cycles, but this can be sort of a little tool in your toolkit of things to use for these menstrual migraines. Now, the goal for treatment in those with menstrual migraines is to reduce that drop in hormone and to stop ovulation. One of the ways that we can do this is with the use of hormones like progestin only and/or combination type contraception, meaning estrogen plus progestin. The progestin only method is generally a good fit for those who can't tolerate estrogen, whether it's due to side effects or they have migraines with aura. In the US, we have several different options, and the majority of these will actually cause a patient's period to stop by around the 6-month mark. But prior to that, it can cause irregular bleeding, which can be really frustrating, and you're going to hear from your patient about it. Combination options have more predictable bleeding, so it can feel more regulated than a progestin-only method. Within the first 3 months, you can also skip your period on purpose. With this option, by avoiding the placebo pills and days and jumping to the next pack, ring, patch, what have you. By doing this, you're avoiding that estrogen drop. Some patients will need to allow for an active pill break due to breakthrough bleeding, Some don't have to worry about it at all, and they can just keep skipping and skipping. Non-steroidals can be used in conjunction with triptans or alone in a similar way as we use the Frova and the Naratriptan 2 days prior to onset of their menses. The nice part to this is that we use NSAIDs in patients with dysmenorrhea, right? So 2 birds, 1 stone. And while we here in the US encourage the use of magnesium, if somebody doesn't want to use that, every single night, they can use it just for their pure menstrual migraine, just prior to onset of menses and during their cycle, and then stop them. So talking about magnesium, the most substantial evidence for its effectiveness is in patients who have or have had aura with their migraine. It's believed magnesium may prevent the wave of brain signaling called cortical spreading depression, which produces the visual and sensory changes in the common forms of aura. Other mechanisms of magnesium action include improved platelet function and decreased release or blocking of pain-transmitting chemicals in the brain, such as substance P and glutamate. Magnesium may also prevent the narrowing of brain blood vessels caused by the neurotransmitter serotonin. Taking magnesium 15 days after the start of your period and then continuing to take it until the start of the next period can help manage those menstrual migraines. Now, perimenopause is really where we see in this graph the hormone levels all over the place. This time can be very challenging for women beyond just their medications not working for their migraines as they once were, or worsening migraine symptoms. They're beginning to experience the menopausal symptoms of brain fog, vaginal dryness, mood changes, etc. By our late 30s, we don't produce as much progesterone, and the number and quality of follicles also diminishes, causing a decline in estrogen production and fewer ovulations. As a result, by our 40s, cycle length and menstrual flow may vary and periods may become irregular. Estrogen may drop precipitously or spike higher than normal, and over time, that FSH level rises in a vain attempt to prod the ovaries into producing more estrogen. Although a high FSH can be a sign that perimenopause has begun, a single FSH reading is not a reliable indicator because day-to-day hormone levels can fluctuate dramatically. Now, let's talk about treatment of migraines during the perimenopausal time. It's important to keep in mind what else is happening with your patient. We need to consider all other comorbid conditions like hypertension, mood disorders, depression, anxiety, sleep disturbance. They coexist, and it will be difficult to treat one without also treating the other. So if your patient has hot flashes, tell them to avoid, warm rooms, hot drinks, hot foods, alcohol, caffeine, excess stress, and cigarette smoking. Consider ways to reduce stress and promote more rest with Tai Chi, yoga, meditation, biofeedback. Although many non-prescription remedies reduce hot flashes, it's likely that this is because of the placebo effect. When non-prescription treatments are studied scientifically, they typically are as effective as a placebo. Even if relief is because of the placebo effect, though, you can expect your hot flashes or your patient's hot flashes to decrease by about 30% with most non-prescription remedies such as soy, herbs, or acupuncture. Prescription hormone therapy with estrogen is the most effective treatment for hot flashes. Although using hormones can increase the risk of breast cancer and cardiovascular disease, studies show that benefits may outweigh the risk for healthy women younger than age 60 with moderate to severe hot flashes. The goal is to use the lowest dose of hormone therapy that treats their symptoms for the shortest time necessary. Women with a uterus need to combine estrogen with a progestogen. With migraine neuroscience, we recommend a daily versus a cyclical progestogen, and it's generally recommended to use the transdermal types such as estrogen patches, gels, or sprays, as these maintain stable hormone levels with few fluctuations. There are other options for women with a uterus that combine estrogen with, something like basodoxifin to protect the uterus. It's an estrogen agonist/antagonist, which means it works like estrogen in some tissues and then opposes estrogen's actions in others. If it's not been a full year since your patient's last period and they're a healthy non-smoker, you can consider a combination estrogen progestin birth control pill. So we're getting contraception, we're getting hot flash relief, and we're regulating our periods. Of note, it's not indicated to use hormone replacement therapy purely for migraines. And I also want to make it clear that it's not contraindicated to use estrogen as hormone replacement therapy in people with migraines with aura because it's such a low dose. Okay. Now, those who experience high blood pressure can benefit from antihypertensives for both blood pressure control and for migraine prevention. Here in the US, we love our candesartan, we love our beta blockers, for examples, but there are other options as well. And looking at migraines with mood changes, we have venlafaxine and escitalopram are two of our favorites. We know venlafaxine has been well studied and can really help with vasomotor symptoms. I will tell you, escitalopram is one of my favorites for migraine prevention. It's very fast acting. You're going to know how they're doing in about 2 weeks. You'll get a lot of people that say, we don't use that for migraine, but it really works well. And remember, if you're not treating the mood disorder, you're not going to be treating their migraines effectively. Now, in patients who experience migraine with sleep disturbance, amitriptyline or nortriptyline are ideal choices. As most of us are aware, menopause can bring difficulty in maintaining one's typically well-managed weight, and topiramate is one of the only preventatives that has weight loss as a potential side effect. Now, a new study in 2023 found for female participants with migraine, their levels of the protein CGRP, calcitonin gene-related peptide, that plays a key role in starting the migraine process, also fluctuate. This elevated level of CGRP following hormonal fluctuations could help to explain why migraine attacks are more likely during menstruation and why migraine attacks gradually decline after menopause. Now, of course, we need more, these results need to be confirmed with larger studies, but we're hopeful that they will help us better understand the migraine process. And I bring this up because we love using our CGRP inhibitors, our MABs and our GPANs as preventative options. And so this study was a really good indicator that what we're doing is to keep doing it. We love our Botox for chronic migraines, and we'll talk more about neuromodulators in the next slide, but we love using those as well for prevention. Now, I don't know how familiar you are with neuromodulators, but they're non-invasive options. They don't have to be implanted, they're portable, and patients use them in various ways, and they don't have significant side effects. The FDA calls them non-significant risk devices. And they change the way the brain processes pain by various mechanisms from various approaches. Now, one of the advantages of these is that, besides the fact that they don't have side effects, is that when medications have failed, it's often because, we kind of chose the wrong option. We thought we were targeting something and we really needed to target something else. And that's how medicine works, right? It targets a particular chemical within the brain. And the advantage of going into the brain and slowly changing the nerves is that you're affecting those targets that we know about, but also targets that we don't know about. And so many patients who have had a lack of success with medicines, the medicines have failed one after another, will find that neuromodulators can really help. And it kind of gives them hope again, right? But you need to consider cost here. You need to consider insurance coverage, especially in the US, and how frequently your patient may need or want to use it when deciding which of the neuromodulators might be a good fit. Looking at, I just want to make sure I didn't skip this slide. Looking at our abortive treatments, we have our triptans, right? These are our OG of abortive treatment for migraine. They can still be used very successfully during the menopause period. Just watch for cardiovascular disease. Certain arrhythmias with Parkinson-White, they're contraindicated for use. We love our GPANs here. They have fewer side effects, fewer drug interactions. They do have a bit of a slower onset, but a longer half-life. And we like combining them all together, honestly. Please don't ever forget to offer your patients an antiemetic, even if they don't talk or discuss having nausea. It can help a lot with pain. And I always offer it to my patients as, if you do experience nausea and I'm not right there with you to prescribe something, I'd rather you have it on hand. And then, of course, the neuromodulators. So we can use neuromodulators for both prevention and for acute or abortive use as well. Now, we reviewed magnesium, and it's really one of the most well-studied supplements in migraine prevention. We also have riboflavin, also known as B2, and it's a vitamin that's found in foods such as organ meats, fortified breakfast cereals, oats, dairy, and more. It's unclear how this B vitamin helps with migraine, but it may be because riboflavin helps with energy metabolism of the cells and decreases certain neuroinflammatory substances. People living with migraine have been found to have lower levels of riboflavin compared to those without migraine. And a study that I referenced here later at the end of this presentation found that supplementing with 400 milligrams of riboflavin decreased the number of headache days compared to placebo, but as usual, more studies are needed. Now there's CoQ10. It's a compound that's present in almost every cell in the body and is largely responsible for energy production. CoQ10 may help those with migraine by decreasing inflammation, improving cell energy, and reducing CGRP. A study found that when CoQ10 levels are lower in those with migraine than in those without. And a recent review of 6 studies found that CoQ10 was effective in reducing the duration and frequency of migraine attacks. And last, we have omega-3. It's a fatty acid that you have to get from your diet, right? Your body does not make this naturally. Omega-3s are thought to be beneficial for migraine because they regulate serotonin levels in the brain, they reduce inflammation, they decrease the number of inflammatory proteins. Common sources of omega-3s include fatty fish, flaxseed, chia seeds, walnuts, soybeans, and a study found that diets high in omega-3s were able to reduce the frequency and intensity of migraine attacks. And this study also found greater results when the diet had high levels of omega-3s and low levels of omega-6s. Now, there are other supplements that you will hear about from different types of providers and different healthcare providers, but these are I will always tell my patients to take these. Go ahead and get started on these because there are very few drug interactions and risks. There are other ones, few, that I don't always recommend depending on the patient's health status. So these are my 4 favorites. Now, thinking about menopause, we know that 75% or 3/4 of women who experience migraine will have complete cessation of their migraines after menopause. So this is great news, but that still leaves 1/4 of our patients who will experience migraines still or potentially have worsening of their existing migraines. The same treatments apply and the same considerations that we reviewed apply. Now, something that I get a lot of questions about dealing with surgical menopause, when a woman has had a hysterectomy with ovarian preservation, we know those hormones will still fluctuate for a little bit and they'll take some time to stabilize. So it's not a light switch that kind of cuts on and off like when we have the ovarian removal. So you have a sudden drop in estrogen, and up to 70% of women will experience worsening migraines. So if you know your patient's going to have this type of surgery, be prepared and be ready to hop on to make sure that we're really optimizing their migraine care. Now, this study just came out. I just added this slide yesterday. A new study was published this month reporting that women in menopause who have both migraines and vasomotor symptoms have a higher risk for heart disease or stroke. The study averaged data from nearly 2,000 women ages 18 to 30 enrolled in the NHLBI-funded Coronary Artery Risk Development in Young Adults, also known as the CARDIA study. The research team followed the women for 15 years and recorded cardiovascular disease events and strokes, combined with data on frequency of migraines and vasomotor symptoms during the study period. It was as if they knew I was giving this presentation and they needed it published. The researchers discovered that the risk of developing heart disease was 1.5 times greater among women who regularly had both early adulthood migraines and persistent and frequent vasomotor symptoms during menopause, compared to women who very rarely or never had these symptoms. Additionally, the women with combined migraines and vasomotor symptoms had a 1.7 times greater risk of having a stroke, yet having a history of migraine or vasomotor symptoms alone did not increase the risk of heart disease or stroke. The researchers also found that the risk levels for both heart disease and stroke declined after the team adjusted for traditional cardiovascular risk factors such as cigarette use, cholesterol, blood pressure, those kinds of things. So what does this mean for our patients, right? We need to listen very carefully. We need to ask the appropriate questions to help parse out if your patient is experiencing signs and symptoms that need to be followed up on or monitored more closely. And as usual, we need to encourage them to live healthy lifestyles, quit the smoking, moderate alcohol, increase exercise. Let's really make sure we're eating well. It makes a big difference. So what are hormone replacement therapy effects on migraine? Well, the general consensus is that 75% of patients will have no change in their migraines when they start HRT, or they'll have improvement. And then 25% will have worsening symptoms. So keep in mind that we generally ask our patients to give treatments at least 6 weeks worth of an effort unless they're having significant side effects, and tell them reach out with any questions, right? Don't just hang on and think, oh, well, I can put up with it. We want to know right away. We like to see effects after 3 to 6 months for other medications, right? We think CGRP, hormone replacement is another one. Of course, so you likely are not going to see immediate changes, but so this is where the importance of tracking your headaches comes in. Now, I pulled this from the Association of Migraine Disorders. I really like this headache tracker. It helps the patient and it helps you. So the longer your patients track their migraine, the more both of you will get out of the tracker, right? It's considered one of the most important tools in both the patient and headache specialist toolkit. Over time, patterns will begin to appear, helping us to understand patients' triggers, how the medications are affecting the patient, and more. Now, one of the major benefits of tracking is that your patient can literally bring this in to you. They can email it to you. It helps to improve your treatment strategy. It also helps to decide, if hormone replacement therapy is improving or worsening migraines. I will tell you that I make treatment decisions based off of headache trackers all the time. Patient will tell me I had a headache for X amount of days, and when I look, I can see on the tracker, it was really just one long headache, right? So optimizing their abortive there may be a better choice than changing their preventative. It's so much easier to look at a document like this than it is to rely on memory and to recognize the patterns. So how should you track your migraines? Well, there isn't a best answer. Many people find smartphone apps to be the most accessible, but spreadsheets and journals can be just as useful. Whatever works for your patient works for me. All right, so in conclusion, right, just a little bit of a summary. What I want to remind you is that don't change someone's medication if it's working for them. If it's broken, right, don't fix it, right? If it's not broke, don't fix it. So I want you to just remember that menopause is not the end of the world. Some studies just came out in the Lancet yesterday that it's not some dark hole, right? Many women do really well, and many people are really excited, honestly, to go through menopause. What I like to tell my patients is that there is light at the end of the tunnel. If you find that the medicines that are not typically working for you, you're struggling, you're really feeling like you're just having headaches more and more, we're going to get you through it. But the majority of women will have complete cessation of their migraines after menopause. So there's hope, right? So we just got to get you through it. Consider adding on hormone replacement therapy. If you are not comfortable prescribing it, reach out to a consultant, reach out to somebody who is, and help your patient, because if they're experiencing hot flashes and night sweats and they can't sleep because they have insomnia, their migraines are not going to get better. We have to really treat the whole person. And consider those medications that have the multiple benefits. We really do love polypharmacy and headache medicine, but if you can use one medication, venlafaxine, for mood, for vasomotor symptoms, for migraine, for all the things, then choose that one rather than adding on 3 different medications. I'm a big proponent of exercise, yoga, Tai Chi, whatever they have in their community that works for them. I work for a primary care organization that provides Tai Chi to their patients every week. So it's whatever your patient's willing to do, get them moving. It will help cognitively. It will help so much. And partner with your patient. I always tell my patients, this is plan A. How does this sound to you? And we have plan B, we have plan C, we have plan D. Don't give up. Right? I don't have a magic wand. I can't necessarily do it that way. But if you stick with me and you build that foundation of trust with your patient, they will do whatever you ask of them. I truly find that if they trust you, they're on board. Because, I have a lot of patients that say, I don't want to be on an antidepressant, Carolyn. I'm not depressed. I don't want to be on something that will change who I am. And when we go through the mechanisms of action, when we go through the why behind what the medication choices and the options that we're going through, they're much more likely and much more willing to participate. So those are just some little tidbits at the end. I wanted to include the references. A lot of things that I reference are in here today. And so more to come. Again, hop on the Lancet. You'll see all the new menopause information. I just wanted to say thank you to the IVPN network and the Association for Migraine Disorders for asking me to speak today. Truly a pleasure. I've loved getting to spend the time with you, and am open to any and all questions.
Thank you, Caroline. Very nice, comprehensive, different flavor.
Yes.
Very fruitful. Sorry for being not on time to introduce you. My computer restart. So do you hear
No
me
problem.
now?
It is the internet, right?
Yeah, no, the computer restart by itself. I don't know how to stop it. So anyhow, thank you very much. I will see first the box of question and answers. Okay, there are good evening for everyone. Caroline, people, the physician and the doctors always ask, does catamenial migraine, menopausal migraine go through the same pathogenesis of migraine through CGRP pathway, or is there a different pathway?
Yeah, no, they're thinking it goes through the same pathway. It's just a matter of, because those hormones are fluctuating so much, you saw in that graph, they go up, they go down, they go up and then down. The brain is so confused. The brain wants everything to be like this, and all the brain is getting is this. And so right now they believe the pathways are the same, right? Especially with the CGRP pathways. They're really seeing with the research that just came out that is a big pathway. And so definitely use those inhibitors for your patients. But nothing new has popped up. More studies are needed. Women are historically understudied. So very exciting to hear more studies are coming out. But honestly, I do love an anti-CGRP. I think they're fabulous. But if some of the older medications are working well for your patient, don't change it. But I have a lot of women that do really well on the GPANTs and the CGRPs because of that.
What in case if the characteristic of migraine during period or during menstruation are not characteristic of migraine? Some ladies are suffering from headache during their period, their menstruation, but the characteristics are not compatible with migraine. It is more like fullness, heaviness, although sometimes it has nausea, but again, doesn't fulfill always the criteria for migraine. Do you still give
Yes.
CGRPs? Do you still
Yeah.
give triptans? What do you give? Do you
It's a great
differentiate usually? Do you ask about characteristic of headache during the menstruation?
I do, because if you can treat someone's pure menstrual migraine, you can make a significant difference for them. The funny thing about migraine is, especially in the US, we do a really poor job of diagnosing it, right? There's lots of different headache disorders, but migraine is the most common. And so many people will say, oh, I have a tension headache, or I have a sinus headache. If they're having any level of disability because of their headache, even if it doesn't match up to what a migraine should be, we call it migraine and we treat it as such, right? Because tension type headaches, we don't generally see people coming in for issues with that. We do every now and again, but the medications that can be used to treat those can also be used to treat migraine. And so typically, because we're bound to insurance requirements here in the US, we have them try and fail to oral preventatives and then move them on to a CGRP. If we could put them right on it right away, I would. Honestly, I would. I give them a little bit of time, right? Let's see how it works. Many of my patients, especially with some of the newer GPANTs, have almost immediate relief. I mean, they are just feeling so much better. Now, for menstrual migraines, especially those triptans or the GPANTs, if you can help get a leg up on it and try it 2 days before, or use their birth control to skip their period altogether, it's gone. They don't have it. They won't experience it, and they don't have to worry about having migraines during that time of their cycle, or having a cycle at all, really. And so we are very quick to treat it as migraine, even if it doesn't sound like it, if it doesn't walk or talk like a duck, but has one teeny little component, we will treat it as such, because it's just so commonly underdiagnosed here in the US.
If a lady patient is expecting exactly her menstruation, her period, do you start usually like G-band, Nordic, prior to the period itself by 1 day or 2 days usually?
Yeah, I do it
And
2
do
days.
you ask the patient to use uh, G-bands on daily basis, or
No.
still start to use every other day, or how do you
Yeah.
prescribe?
So it depends on which GPANT we're talking about, right? But yes, daily. We'll tell them to take it daily, either once daily or twice daily, whether it's your Megapant or your Brojapant. And so if triptans are not something that work for them, we always have to try triptans and fail before we can get insurance to approve GPANTs here in the US, right? So if the triptans, they have migraine with aura, they're contraindicated, they can't do whatever, they have brainstem or retinal migraines, and they do GPANTs, yes, we tell them to take 2 days prior to the onset of your menses, and then certain days within. Now, that means they're going to run out of their medication, right? Because they only get so many. So that's why it's nice to have other options and to give them additional neuromodulators and that kind of a thing. But their period has to be predictable. They have to be able to keep track of it and say, oh, my period's starting in 4 days. I'm going to start my medicine 2 days before. And so it can be very successful. There's not a lot of great research on GPANTs for menstrual migraines. We have been using it as such for several years because if our patients can't take triptans, right, then of course a GPANT is the way to go. And I've had a lot of success with patients who've both used GPANTs, triptans, and or birth control to sort of stop those menstrual migraines.
Okay, there is a question here. Would calcium supplements help? You mentioned, yeah.
I mean, it's not going to hurt. It's not going to hurt you. But certainly, there's been no research that shows that it's been statistically significant in terms of a difference and an improvement.
Okay, I see. Another question here: is it suitable to treat migraine as menopausal symptom by triptans, or is more reasonable to treat the underlying cause by HRT? So, if there is a migraine as part of menopause syndrome, do we treat the migraine as a symptom of menopause, or just we suggest HRT as therapy for the whole complaints?
Yeah, so generally, we don't think HRT is going to fix your migraine, right? We don't think just what and what you prescribe for migraine can sometimes help with the vasomotor symptoms, right? So it would be my recommendation that you start off with something like venlafaxine, see how your patient does. If the vasomotor symptoms, if the genitourinary syndrome of menopause continue, you need HRT, right? And so you're never going to use HRT for migraines, right? So that's not going to fix all of that there, but certainly within the migraine realm, using HRT to help your menopausal symptoms, if what you're using for migraines is not helping, is appropriate and should be used.
Okay, when it comes to magnesium, usually if you are going to treat migraine related to menses, how do you prescribe magnesium? Do you start all months? That patient start all the months whenever the patient is usually suffering from migraine during menses. Do you ask her to stay all the time during on magnesium? Do you
So
prescribe it daily or twice a day?
yeah, so I personally like my patients to take magnesium every single night. But if they say, I can't tolerate it, it's too tough on my stomach, I'm having, too much GI upset, and we know they just have pure menstrual migraine, we certainly can have them take their magnesium. And I think I had it in a slide, and we'll share those with y'all, that 15 days after the last menstrual period, start taking it. It's just once a day. And it can make you sleepy. So bedtime is a good time to do it. There's different forms of magnesium, whether it's magnesium oxide or magnesium, glycinate, whatever the case may be. Your body digests them differently. So if you can't tolerate one, try another. Don't give up and say, magnesium's not for me, I can't do it. And there are certainly supplements out there that combine a lot of these together, magnesium and B2 and different things like that. So there are, side effects. Again, you can feel sleepy, you can have GI upset. B2 can change the color of your urine, turns it bright yellow. Warn your patient, right? So they're not freaking out the next day whenever they see that. But generally it's 15 days after the end of the first period for your menstrual migraine throughout the next period, and then they can stop it. But honestly, that's half the month, right? So if they can do it, take it every single day. It's very good for them. We're big proponents of it, 400 milligrams. Hard to find here in the US, right? So if you have to take 500 milligrams, that's fine. No big deal. You might find the 200 milligrams, you can take 2 of those, or if they seem like horse pills, just take a 500.
Okay, so we talk about menses, menopause. What about pregnancy?
Yeah, pregnancy is a whole different conversation,
Pregnancy.
right? It's a whole different conversation. And what I generally say to my patients is there are definitely medications that you can take when you're pregnant, right? Lots more studies needed on some of the newer ones, but I know a lot of people who prescribe different things. And so we hope that someone's pregnancy will actually improve their migraines. And if they have menstrual migraines, they're much more likely to have a complete resolution of those migraines during pregnancy. Now, when the pregnancy ends and they start breastfeeding, all of a sudden the migraines come right back. So they have to be prepared for that, right? That can also be a stressful time. So for those who don't have improvement in their migraines and they actually have worsening, yes, they can definitely use different medications they can use. So Sumatriptan is a very common one typically used, and metoprolol is a preventative. But you have to be very careful during pregnancy, right? Because if you have any new changes in your migraine, which can happen, they need to be followed up on. We may need head imaging, right? We're a lot more cautious during pregnancy because there's fewer things we can use to treat, but also some bad things can happen. So for your patients, and I don't personally treat pregnant patients, but I do consult for them for OBGYNs. I think it's really important that they just stay in contact with their healthcare provider, their midwife, or whomever, to say something is different, something doesn't feel right. And even if it's just, I feel worse, that's okay, right? There are definitely different options. And the neuromodulators, many of them are indicated to safely to be used during pregnancy. So those are great non-pharmacologic options as well.
So for menses related migraine, do you use Diamox, acetazolamide?
We don't, no. Every headache specialist here in the US has their favorites, but it's not one that I commonly use. But certainly I'm sure it can be used by different people, but it's not one that I use or recommend.
Okay. I think no more questions now. So thank you very much, Caroline.
Thank you.
It was nice having you on this platform, and hopefully we'll see you again. Thank you very much.
Thank you. Take care.
Bye. Thank you. Bye-bye. Okay, thank you very much. I think it is time to move to our next speaker, Colleen Jaddam. Colleen, you are mute. Anyway, I'm gonna to introduce Colleen. I think I'm having... Okay, Colleen. So, Colleen, you are working now in ACBN, right?
Yes.
Okay, so this is an old dame biography. Colleen is a consultant
You
at
are always more updated than everything
they
said
give me
by
the old thank you. So they give us an old bio. I think it needs to be updated. Currently, she's consultant neurologist at American Center for Psychiatry and Neurology at in Abu Dhabi. She is Karin graduated from Saint Joseph University, Hotel de France in Lebanon. I will not say when, so she's still very young. She has a degree in critical care neurology from Paris 12, and she's having also a fellowship in neurophysiology and epilepsy. So she's interested, in fact, in critical care neurology, in stroke, in EEG, in epilepsy. Additionally, she is holding the position of assistant professor of neurology in Belmont University Faculty of Medicine in Lebanon. Colleen is gonna to tell us today about everything we need about G-band, everything we need to know about oral G-band receptor antagonist. That's right?
Correct. Thank you so much, Doctor, for your kind introduction. I will head to share my screen.
Please. So our attendee, please just, there is a box here for question to answer. Please place your questions in this box. It's not for a greeting. It's not for say good night. Thank you very much. It's only for question. Thank you very much, please. Colleen, the stage is yours.
Thank you so much, Doctor. So we're going to tackle tonight the subject of Nurtec or rimegepant as a novel treatment that is indicated and approved for both acute treatment of migraine and preventive treatment of migraine. So why are we still speaking about migraine and all these migraine lectures? First, because migraine is a very highly prevalent disease, around 10% globally. So wherever we are, wherever we practice, there is one chance in every 10 patients we see or in every 10 people we encounter in any social contexts that might have a migraine. And second, these patients who have migraine are usually disabled from their migraine. And this is a major cause of a global disease burden and global disability. And that comes usually second to low back pain, and that comes more frequently than other disabling chronic conditions. Second, we are speaking of novel therapies. We are the lucky physicians practicing in the era of novel migraine treatments, because up till 2018, we had hugely unmet needs in terms of diagnosis, because a large chunk of migraine patients remain undiagnosed for several years, or incorrectly managed for several years, or undertreated, or even not treated except with acute medications like painkillers, etc. So we had a huge gap in terms of diagnosis, management, and a gap and unmet needs in terms of treatment. So while we tackle first the rimegepant as an acute treatment for migraine, the unmet need still now for the acute treatment of migraine was that the triptans, it was the only available anti-migraine acute treatment up till very recently. So these triptans, although they were offering an acceptable efficacy to control and to abort migraine attacks, this was usually at the cost of adverse events, at the cost of poor tolerability, etc. And most importantly, at the cost of cardiovascular risk and cardiovascular adverse effects. And that's why a big chunk of migraine patients, migraineur, would be unsuitable for triptan use. So tolerability issues, cardiovascular contraindication, and on the other hand, usually triptans did not offer, did not secure, if we can say, pain freedom that is sustained throughout the day, and the need for rescue medication usually is very frequent with these medications. Not to forget the risk of medication overuse headache due to chronic sensitization that we observe in migraine and chronification of migraine, and medication overuse headache related to all abortive treatments, whether it is the paracetamol, NSAIDs, or triptans. So these were the limitations that led us to say we need a novel acute treatment that is efficient from one side and from the other side would not cost us in terms of tolerability, adverse effect, sustained response, and medication overuse. So triptans have been considered the standard care for the acute treatment of migraine, but around 30 to 40% of people did not find triptans to be sufficiently efficient in controlling their migraine. Switching to a different triptan provided pain relief at 2 hours for only 25 to 50% of patients. So it was a bit left to a chance probability, and up to 40% of patients surveyed were not satisfied with the need for a rescue medication with triptans. Also, 40% of patients experience treatment-emergent adverse effects. It's usually chest tightness, dizziness, nausea, a feeling of tiredness, etc. And usually we are surprised that patients bear with these side effects long enough just to control their migraines, but they long to find a better acute treatment for their migraine without experiencing these adverse effects. So what we know till now that migraine is a CGRP-based disease. So all novel treatments for migraine, whether it is acute treatment or preventive treatment, they would all target the CGRP. CGRP is a pain signaling neuropeptide that is, during the migraine, released from the trigeminovascular system in the brainstem and the trigeminovascular system afferents from the face, from the meningeal vessels, etc. And so it is implicated in different components of the pathogenesis of migraine. And we found that migraine patients usually have sustained increased levels of CGRP versus normal non-migraine patients. And these levels increase furthermore during a migraine attack. So CGRP is usually implicated, as we said, in many components of migraine pathophysiology, whether it is the vasodilation that is usually responsible of the throbbing nature of the migraine attack, but also it is implicated in neurogenic inflammation and in peripheral sensitization and even chronic sensitization. And usually this pathway is what we target when we use Botox injections, etc. We target the CGRP that is released peripherally rather than the CGRP that is released centrally. So the CGRP mechanism, all this mechanism usually is not associated with medication overuse headache. So one would imply that by targeting the CGRP, we would have an effect on controlling migraine without the side effect of the risk of medication overuse headache. So the first treatment, anti-CGRP treatment that was targeting this CGRP pathway was rimegepant. Rimegepant, that is a small molecule that competitively antagonizes with the CGRP receptor. And in the studies that were led to assess the efficacy of rimegepant for acute treatment of migraine showed that 2 hours following first dose of rimegepant, we had a significantly higher rate of pain freedom than placebo with a significant P, and significantly higher rates of freedom from most bothersome symptoms and of pain relief. So to dissecate all this, we all know that during migraine, it's not only the headache that is bothering the patient. Sometimes the associated symptoms like nausea, photophobia, phonophobia are really invalidating, and they are really bothering the patients. So this is a considerable outcome and a very satisfying outcome in these studies to demonstrate that rimegepant not only offered pain freedom, but also offered pain freedom from most bothering symptoms. And for patients who did not achieve pain freedom, meaning zero pain, we had a considerable advantage in terms of pain relief. Pain relief is not zero pain, it's decreasing pain to a level where the patient can be functional, can go out throughout his day, etc. Of those patients who achieved pain relief at 2 hours, more than 2/3 of these patients experienced sustained pain relief. And this is a second very significant outcome for us. So the first message was acute and rapid pain relief or pain freedom and freedom from most bothering symptom. The second message is that this pain relief was sustained throughout 48 hours without need to repeat dosing, and almost 86% of patients on Nurtec did not require rescue medication in the next 24 hours versus 70% with placebo with a highly significant P. So this was for pain relief. On the other hand, for pain freedom, 63% of patients taking Nurtec ODT who experienced pain freedom had this pain freedom sustained throughout the next 48 hours post-dose without need for rescue medication. So what are the current recommendations and guidelines from the American Headache Society concerning the acute treatment of migraine? For mild to moderate attacks, we still use the usual NSAIDs, non-opioid analgesics, acetaminophen, paracetamol, etc., or other caffeinated combination drugs. For moderate to severe attack, we can use migraine-specific agents that are either triptans, or small molecule CGRP receptor antagonists like the gepants or even the ditans. And the criteria for initiating gepants, ditans, or neuromodulatory devices for acute treatments are usually, it should usually be for an adult patient, so 18 years and above is the cutting age limit, with a diagnosis of migraine, whether it is with or without aura, or chronic migraine as an acute treatment for chronic migraine. They should have either contraindication or inability to tolerate triptans or inadequate response to 2 or more oral triptans as assessed using a validated acute treatment patient report outcome questionnaire. So these are usually for patients that are non-responders to migraine, to triptans to treat their migraine attacks, or who have high cardiovascular risk profile with contraindication to triptans, or for patients who cannot tolerate triptans. The onset of pain relief can be as early as 15 minutes, but it differs for patients. So every patient can have a pain relief different than the other, whether they take it at the beginning of their attack or not, whether they have a long-lived migraine, a very severe migraine, etc. So there is a sustained benefit throughout the next 48 hours, and usually the need for repeat dosing, the rescue medication is very low, and the half-life is 11 hours. And this is very interesting, and we will discuss this later as it will gain territory in terms of many prophylaxis, in terms of pregnancy, rapid washout in case of serious adverse effect, etc. So viewing all these pharmacokinetic characteristics, so one would conclude that we are using fewer pills because we will need mostly one pill per migraine to treat more migraines per pills. Coming to the preventive therapy of migraine, because Nurtec is the only available migraine-targeted treatment that is approved for both acute and preventive treatment. So up till also 2018, and this is very recent, all we had was the repurposed treatments, whether it is the antidepressant, tricyclic antidepressants, anti-epileptics, antihypertensives, etc., beta blockers, that were used as preventive treatments for migraine. And usually these treatments offered more or less acceptable or suboptimal efficacy, but this efficacy was delayed. It was not during the first few days. We usually had to wait several months to have the full effect of the preventive treatment. They were poorly tolerated due to adverse effects that are obesity or side effects related to cognitive dysfunction, memory impairment, attention impairment, etc., fatigue, depression, etc. And this led to high discontinuation rates due to this poor tolerability profile. After 2018, we had the monoclonal anti-CGRP antibodies that were a breakthrough for migraine management. And these monoclonal anti-CGRP demonstrated efficacy and safety. So they were a good relief for both migraineurs and physicians. But we had some drawbacks related to monoclonal anti-CGRP, related first to the long half-life, which makes it not the best option for patients planning for a pregnancy, etc., due to the long washout period required, usually about 6 months. Around 34.7% of the patients receiving 6 months of monoclonals reported wearing off response. And usually this is an effect not only in erenumab. The wear off headaches are observed more or less throughout all the monoclonal anti-CGRP because they are offered on a monthly or a trimester basis. So one would expect a wear-off effect toward the end of the dose or toward 1 week before the next dose. And so this is where the Japans gain territory in terms of wear-off headaches, whether they are giving every other day or on a daily basis. They would offer less or none wear-off headaches versus the monoclonals. or they can be offered as a bridging therapy for patients already on monoclonals and patients who had a good clinical response on monoclonals. So we can offer the gepants as a bridging therapy at the last 1 week or two, depending on the monoclonal we are using. So on the last 1 week or two before the next dose, they can be offered as a bridging therapy, or they can be offered as a preventive therapy with low risk of wear-off headaches. And the third drawback is related to patient preference. There are patients who prefer to take a monthly medication or a once every trimester medication, but there are other patients who prefer to have a tablet than to have injections and possible adverse effects related to injection site reaction. So concerning the studies that were led on rimegepant as a preventive treatment, we had a reduction of MMD monthly migraine days of 4.3 days from baseline during the weeks 9 to 12. And even this effect was observed during the first week of treatment. And this is a major win for us versus the previous repurposed drugs where we had to wait several weeks for the drug to kick in and give a clinical effect. So rimegepant produced 30% reduction of weekly migraines in the first week of treatment and 4.3 days reduction from baseline MMD in weeks 9 to 12. And this gain was sustained throughout the 52 weeks period with over 16 months treatment period and a gain of approximately 6.2 days in terms of monthly migraine days. The most recent study that came in favor of rimegepant was a head-to-head study versus galcanezumab. Galcanezumab that is usually known as a very efficient monoclonal anti-CGRP antibody. So this was a head-to-head trial. It was a phase 4 double-blind randomized double-dummy trial of rimegepant 75 milligram ODT versus galcanezumab 120 milligrams sub-Q for the preventive treatment of episodic migraine. So patients were randomized to receive either galcanezumab or rimegepant. The primary endpoint was the percentage of participants reaching 50% reduction in MMD, and secondary outpoints were a change from baseline in the number of MMD and monthly headache days, and proportion of participants with 75% reduction of MMD. And the data was very satisfying that rimegepant showed no significant statistical difference versus galcanezumab in terms of 50% response rate. And concerning the safety study, adverse effects were close to placebo, or really adverse effects that were really related to the rimegepant were very rare or close to placebo. So this is a safety trial for rimegepant for both acute and preventive treatment of migraine. There were 2 arms of the study, a 52-week study for rimegepant used as needed to treat attacks for of any severity up to once per day, once per calendar days. And another arm of a 12-week treatment period of rimegepant taken every other day. So this is the preventive treatment regimen. And also the adverse effect came very infrequent and rare They consisted mainly of nasopharyngitis, sinusitis, nausea, etc. Serious adverse events were close to zero. No clinically relevant lab abnormalities were observed. Only one serious adverse event considered by the investigator to be possibly related to rimegepant was detected. And most importantly, because we spoke at the beginning of our talk of cardiovascular contraindication for patients who wish to receive triptans, etc., that was not the case for patients on rimegepant, because we stratified patients according to their cardiovascular risk factor and the Framingham risk score. And rimegepant was consistently demonstrated to be safe for all cardiovascular risk profile categories, with the limitation that patients that were that had evidence of uncontrolled, unstable, or recently diagnosed cardiovascular disease were excluded from the study. So further, more comprehensive studies would be needed to have even more reassuring data. The majority of adverse events were mild or moderate in intensity or unrelated to rimegepant. Concerning the 50%, the 75%, and the 100% reduction in moderate to severe MMD, we observed that it was not only sustained, but it increased during the weeks, whether it is for the 50%, the 75%, or even the 100% reduction. So this is usually very reassuring in terms of sustained response to this drug, and in terms of no wear of headaches, viewing that it's an every other day dosing, so wear of headaches are not expected. For rimegepant taken as PRN in PRN cohorts with more than 6 MMD at baseline, we had almost 17% gain in pain-free hours. We had 25% decrease in mild pain hours, 45% decrease in moderate pain hours, and 45% decrease in severe pain hours. And these data are very encouraging. In terms of preference and satisfaction, patients were satisfied with this drug, and usually the most preferred and the satisfying regimen is the every other day regimen as a preventive treatment, plus PRN dosing for breakthrough headaches throughout the course of treatment. A current network meta-analysis suggested that Nurtec has a comparable efficacy, not only versus galcanezumab, but versus all the available monoclonal anti-CGRP. It has a convenient administration because it's a tablet that we put it under the sublingual. It doesn't need even a glass of water. It's very handy. It has demonstrated high tolerability. It has short half-life, and this is usually very practical for us physicians in case of serious adverse event, even if it is a very rare possibility in case of pregnancy, or even practical for us to be used as a mini prophylaxis for menstrual migraines, etc. And there is no attenuation on effects, no wear of headaches. The long-term use of Nurtec has demonstrated a favorable tolerability profile when used as acute or preventive treatment. Nurtec's half-life allows for both preventive treatment and cessation, immediate cessation if needed in the event of pregnancy. And what we, in the real world, what we are observing is that even for patients who are using Nurtec as acute treatment on the long run, throughout the weeks and months, they will have a reduction in their monthly migraine days. It's as if this treatment used as acute treatment can have a preventive effect, even if it's not given in the preventive treatment regimen. And this is to be proved later on with real-world evidence studies. So Nurtec is the first and only medication to treat migraine and prevent migraine in episodic migraine in adults. It's an oral dissolving tablet for the acute treatment. So we take it at the beginning of the migraine attack. The recommended dose is 75 milligrams, so 1 tablet only, not more than once daily. And it won't be, more than once daily won't be needed anyway. For preventive treatment, it's 1 tablet, 75 milligram every other day. Nurtec is not contraindicated in patients with cardiovascular risk factors or stable cardiovascular disease, just because those with uncontrolled, unstable cardiovascular disease were not studied yet. Co-administration of medication, a small note on this, because many of our patients usually are on polymedications. The only thing to worry about concerning drug-drug interaction is the concomitant use of CYP3A4 inhibitors or CYP3A4 inducers. Usually concomitant use of Nurtec with strong inhibitors of CYP3A4 should be avoided because it can induce a high increase of Nurtec exposure. But with other less potent inhibitors of CYP3A4, mild to moderate inhibitors, we can use Nurtec, but we should avoid another dose in the next 48 hours because the level of rimegepant will be increased in the body. So usually for regular patients, we tell them it's 1 tablet per day. For patients on mild to moderate CYP3A4 inhibitors, because of the slight increase of Nurtec in the body, we would tell them to stick to 1 tablet every 48 hours. And if they are using high or potent inhibitors of CYP3A4, it should be avoided. Concomitant use with strong or moderate inducers may decrease exposure to Nurtec, and this may affect the efficacy, and this should be kept in mind. So last note, we should avoid use of Nurtec in patients with severe hepatic impairment because it has a hepatic clearance, or with end-stage renal disease. And with that, I thank you, and I'm ready for your questions.
Thank you, Colleen. It was very informative. Again, very comprehensive presentation. I have many questions here in the box of questions and answers. Okay, let me start with the first one. Here, they are asking about the exact pathophysiology of migraine. I think you already mentioned it. If you can just give a brief again.
The exact pathophysiology is the activation of the trigeminal-vascular system that uses afferents from the trigeminal-vascular facial afferents and from the trigeminal vascular receptors in the meningeal vessels. So these are usually the afferents from the meningeal vessels and from the trigeminal system. They are relayed in the brainstem and the trigeminal vascular nucleus. And then we have second-order neurons relaying it to the thalamus and to the cortical areas. And then in response, we would have release of neuroinflammatory peptides, and this is what we call the neurogenic inflammation. And many neuroinflammatory peptides usually are implicated in these mechanisms. The two most famous neuropeptides being CGRP and P substance. CGRP is now the key neuropeptide that is targeted both in acute treatments of migraine through the Japans, or in preventive treatments of migraines through a new class Japans or monoclonal antibody. Another sub mechanism would be related to peripheral sensitization, chronic sensitization, and these are usually subcategories related to chronic migraine, and these are what we target usually upon injecting Botox, and Botox injections would be targeting the release of neuropeptides peripherally around the nerve endings rather than targeting the CGRP that is released in the trigeminovascular system. So before we used to speak about vasodilation being the mainstay of pathophysiology. Now we speak more of CGRP, that is the main cause of vasodilation, neurogenic inflammation, etc. And there is also the cortical spreading depression that is usually implicated in the migraine aura. But now the mainstay of treatment revolves around CGRP and CGRP-induced migraine mechanisms.
Thank you, Colleen. Another question here about how to counsel patient who is taking rimegepant for pregnancy, who is planning for pregnancy. A lady who's taking rimegepant, Nordic, and she's planning for pregnancy. What do you give recommendation? How to counsel this patient?
Yeah, so rimegepant, as we said, has a short half-life of about 11 hours. And this is usually very practical for patients planning for pregnancy, because when we stop it, we will need a washout period of around 4 weeks of 1 week to get rid of the rimegepant in case of pregnancy, whether it is accidental pregnancy or planned pregnancy. It's usually 5 half-lives. So usually 1 week is sufficient, and this offers high practicality for patients planning for pregnancy. And it's also very practical in this setting also for patients having menstrual migraines, because nowadays we are using it a lot as a mini prophylaxis for patients who have regular cycles and who have expected menstruation dates. They can start the Nurtec like 2 days before the menstruation, throughout the menstruation, and 2 days after.
Do you give usually daily or every other day?
Every other day.
Every other day. Okay, there is another question here about combining therapies, the daily oral therapy and the monthly injections, especially for the refractory migraine. What's your input?
In fact, we are doing this, but I shouldn't say it. We are doing it as an off-label indication. Off-label, we are using it as a bridging therapy for wear-off headaches for patients that are on monoclonals, that are well controlled on monoclonals. They tell you, I'm in a honeymoon for the first few weeks, and then the last week before the next dose, migraine is all over again. So Nurtec can be offered as a bridging therapy, whether it is every other day or daily. But again, this is an off-label indication, but it is now widely used by a lot of physicians as a bridging therapy before the next dose of monoclonals.
What's your experience about Botox and anti-CGRP therapies?
I have a very good experience, but it's not based on studies. It's based on real experience. It can be inspired from pathophysiology, because One acts on A delta fibers and the other acts on the C fibers. So one would expect a synergistic effect that is far more the effect of either therapy used alone. I like to use in chronic migraine and refractory chronic migraines the association of monoclonals plus Botox or Gepants plus Botox. For me, it's an optimal combination and it has a synergistic effect. But I'm waiting for a study on this.
Okay. So another question here, how soon postpartum ladies would go back to migraine prevention, especially if they are breastfeeding?
Usually it's not advised with the breastfeeding for Gepants and monoclonals. They are all not indicated during breastfeeding. But during breastfeeding, we stick to the usual approved medications like magnesium, etc. And it is after breastfeeding has ended that we can offer these novel therapies.
Okay, I feel here a question that is irrelevant. Why there is no such a medicine available in Pakistan? Okay, I think it's not approved everywhere. It's even it's still not registered in majority of the countries worldwide. Same as for the other anti-CGRP, either monoclonals or G-bands. So
Even
what?
in Europe, it recently got the approval. It got the approval in States and then it hit the market in UAE. And it is only a few months ago we knew about the Europe approval, if I'm not mistaken.
Yeah. So what is based on medical history, what is the good candidate for Rimijiband if you are talking about the ideal patient, taking the medical history of the patient? Who is the ideal patient for Nordic? When you think about Nordic as first line of
Yeah, because we have so many options now. We are
crowded
on the
market.
other side. We used to have no options, and now suddenly we have many options. So rimegepant gains a lot of territory for, and it's an obvious gain for patients, for example, planning for pregnancy. For patients having estrogen-related migraines who would benefit from mini prophylaxis. For patients having wear-off headaches, whether we want to switch them on rimegepant or offer them this off-label bridging therapy with rimegepant. So all these are clear benefits of rimegepant over other available therapies. But also it remains an option like any other available novel treatment for migraine in terms of preference for the patients, because there's a big chunk of patients who would not prefer injections, whether they are monthly or every 3 months, etc., and prefer to have this tablet handy if they travel a lot, if they have a lot of a stressful lifestyle, a requiring lifestyle. So a tablet every other day would be very convenient for them. So it depends on patient profile and also on patient preferences.
The question, how long does it typically take for Rimijiband to start working, and how long do the effect last?
So this is
for
inspired from the studies we presented. The effect can be as early as 15 minutes post-dose, but this varies from a patient to another, and it varies if the patient took it as a last resort, because some patients, they, for example, have a migraine and they wait for it till it intensifies to make sure that they will need this medication, and they take it very late after the beginning of the headache. Or if the patient is taking it since the start of the headache, he will have a much quicker response. So it depends on the patient, on the timing of the dose related to the start of migraine, and it is a sustained effect, and that it has a sustained effect. It was proven in studies with high rates of sustained effects through the next 24 hours and the next 48 hours after those. And that's why it gives efficacy in terms of many prophylaxis. So if you take it preemptively before the menstruation, for example, or for people having a jet lag and having a long flight, they would, for example, expect a coming migraine attack. If they take it preemptively, they would prevent the coming migraine attack because of this sustained effect.
In case of a patient take the tablet, the ODT as a tablet and swallow it with water, do you suggest to take another one?
No, usually it is advised to be taken sublingual to offer a rapid onset of action. But if it is taken by mouth with a glass of water, it will have an effect, but the difference will be in the rapidity of onset of the effect, because all sublingual medications have more rapid onset of effect.
In case of unlikely, there was no response to Nordic after 2 or 3 hours, do you suggest to take somatriptan or triptans or any other medications?
Usually, I don't like combining triptans with rimegepant in the same day because in terms of pathophysiology, I tend to stay away from this, although other clinicians would do it. Usually, with the rimegepant, if there is residual headache, we give the usual pain medications, NSAIDs, paracetamol, etc. But the studies showed that associated triptan use was not related to serious side effect, but I wouldn't do it.
Okay, how effective is Nordic compared to other G-bands?
There
What the
isn't a head-to-head
superiority?
trial yet compared to other G-bands, and we must say that there is one other G-band, that is the ubrogepant, that is indicated for acute, and another G-band, the atogepant, that is indicated for chronic migraine. So Nurtec is indicated for acute treatment and preventive treatment of episodic migraine. So we may have a head-to-head trial with ubrogepant in the future, but it's not available yet, and we cannot compare in terms of efficacy.
Thank you very much. I'm not having any other question except for one question. What is the best therapy for episodic migraine?
The best therapy is usually tailored to the patient. As we said, every patient has a profile, every patient has preferences, every patient has his own restrictions in terms of medication choice, etc. So even if we are in a Pfizer webinar, we cannot be scientifically say there is one medication that is the best. This is a very good medication. It proved high efficacy. It proved a highly satisfying safety profile. It is highly practical because of its pharmacodynamic characteristics, etc. But to be honest, we cannot say that there is one treatment that is the best and one size fits all, one size that does not fit all, because there are many profiles of migraine patients.
Definitely. Thank you very much for this
Thank you.
very informative and valuable answers from you. I would like also to thank our attendee for this interactive and excellent interactions with the speakers, outstanding speakers for this night. This is the session 15 of migraine master classes. I would like also to ask to thank IVPN for this is excellent and very unique, in fact, platform for education and CME. There is a question, I think, for IVPN always is existing about CME. I think someone has to answer our attendee about these questions. From our side, thank you very much and have a good night. Thank you for everyone.
Thank you
you,
so
Dr.
much,
Mustafa.
doctor, and thank you to IVPN for this
Thank you for Pfizer for sponsoring this
and
meeting.
for Pfizer.
Thank you, Dr. Mustafa and Dr. Khalil and our speakers. I would like to iterate Dr. Mustafa's word, appreciating the collaboration with the Association of Migraine Disorders in organizing these events with IVPN NeuroPsychiatry and acknowledging our sponsor, Pfizer. I would like to remind the audience that certificates of attendance will be released by email within 1 week of this event. And this event is accredited by the Jordan Pharmacists Association and MOHAB, as well as the OPL in Lebanon. I would like to remind everyone that you can always follow us on LinkedIn to stay tuned for our future events, and that you can always access IVPN recorded webinars on the IVPN library that is currently available for access in the meantime. Until we meet you again, thank you for staying with us until the end, and we hope to see you in future activities.
Thank you. Have a good night. Bye-bye.
Thank you. Have a nice evening. Thank you.